Yeah, thank you for the kind introduction, Chairman. Good day, everyone. I am Hae Sung-jo from Korean University, and I'm deeply honored to have the opportunity to present this study at this esteemed academic conference. Although the pool of living and deceased donors has remained stable for years, the number of patients on the wait list continues to increase globally. Consequently, the distribution of the limited number of deceased donor rivers has led to a serious debate on achieving an appropriate balance between equity and efficiency. With the implementation of the MELD score in the allocation systems, actually we focused more on equity in organ distribution. Many countries have adopted a sickest first policy, prioritizing more critically ill patients. Given that the patient with higher MELD scores indicated of severe illness are at a higher risk of concomitant organ failure, some of them deemed too sick for transplant could result in futile outcomes after liver transplantation. It could potentially in wasting of livers that could have been used in other patients with a concurrent domino effect in wait-list mortality. Therefore, this international multi-center study aimed to identify the risk factors associated with future outcomes of following deceased donor liver transplantation in patients with a MELD sodium score above 30 and to develop an easy-to-use and widely applicable nomogram for predicting futility. Futility was defined as death within 3 months or during a hospital stay following deceased donor liver transplantation. Between 2010 and 2021, 994 patients from the 6 institutions were enrolled in this study. Dedicated hospitals are listed in the right slide. After exclusion, 963 patients were included in the final analysis. Among them, 160 patients were classified into the futile group and 803 patients were classified into the non-futile group. This table shows baseline characteristics of recipients in the futile and non-futile groups. Median age was higher in the futile group than the non-futile group, but the difference was minimal. Regarding MELD sodium score, no significant differences was observed according to the 3 time points, including enlisting and matching at transplantation between the groups. Hepatic encephalopathy above grade 3 was more prevalent in the futile group. In terms of concurrent organ failure factors, the futile group showed a higher instance of organ dysfunction across all measured parameters, including the use of mechanical ventilators, continuous renal replacement therapy, and pneumonia, bacteremia, and vasopressor use. Also, ICU stay was also longer in the futile group. Regarding pre-transplanted findings, there was no significant differences between the distribution of MELD sodium scores is demonstrated in the figure 2 and table. The MELD sodium score increased according to the timeline before the transplantation, so MELD score at the transplant was the highest among the time point. However, no significant difference was observed between the groups according to the 3 time points. This table showed the baseline characteristics of donors between the 2 groups. The proportion of graft with macrostasis exceeding 30% was comparable between the futile and non-futile group. Otherwise, no significant differences was observed in all parameters regarding donor characteristics. This table shows recipient outcomes between the groups. Postoperative peak AST and ALT levels were significantly higher in the futile groups than those in the non-futile groups. Major complications, including vascular and infectious complications, were significantly higher in the futile group than those in the non-futile groups. Additionally, the number of patients requiring reoperation or retransplantation was also higher in the futile group, and ICU and median hospital stays were also longer in the futile groups. This figure shows the cause of fertility in the futile groups. Infectious complications were the most prevalent cause, accounting for over 50%, but graft failure developed in 7.5%. The median time to fertility after deceased donor liver transplantation was 27 days. This table shows univariate and multivariate logistic regression analysis for futile outcomes. It revealed that age over 65 years, lower BMI, and use of mechanical ventilator, prolonged CRLT, and ICU stay before transplantation were independent risk factors for futile transplantation. Based on the number of risk factors, the multivariate analysis observed significant differences in fertility rate and overall survival. We can see that overall survival worsens as the number of risk factors increased. The fertility rate for those with 3 or more risk factors was 53.3%. It is very relatively higher fertility rate. This figure presents a nomogram developed to predict fertility after a deceased donor liver transplantation. The nomogram included significant clinical predictors identified using the multivariate analysis. And this figure is an ROC curve assessing the predictive accuracy of the model. This model had a better predictive value for fertility after deceased donor liver transplantation than the previous model MELD-sodium score and bar, which is balance of risk scores, which are previous better predictive model. In conclusion, independent risk factors for futile outcomes after deceased donor liver transplantation in patients with MELD-sodium score above 30 include recipient age, BMI, and use of mechanical ventilation, prolonged CRLT, and preoperative ICU stay. The nomogram, which adequately reflects concomitant organ failure before deceased donor liver transplantation, could predict the risk of future transplantation and help establish individualized perioperative strategies to improve outcomes after deceased donor liver transplantation. Thank you for listening to my presentation. I hope you enjoyed this international academic conference. Thank you.